Hi guys, we're continuing to discuss neuro-interventional radiology compartment and especially anesthetic considerations for carotid artery stenting. Pre-anesthetic management determines the degree of preparation of the patient to the surgery, establishing the anesthetic risk like ASA or ASA, American Society of Anesthesiology risk, elaboration of the anesthesia plan, and administration of premedication. For carotid artery stenting, the anesthesia is also essential, and not only for sedation of patient, but for monitoring and applying immediately measures to prevent some complications. Assessment of somatic risk factors in patients, like evaluation of the patient's coagulation system, like prothrombin time, activated partial thromboplastin time, fibrinogen, and INR. Lipid profile, like lipid fractions, low density lipoproteins, like HDL, high density HDL, triglycerides, and total cholesterol. EKG and echocardiography and cardiologist consultation in many cases like heart failure, severe rhythm disorders, and pronounced ischemic disease, and consultation of other specialists for additional disorders. Once again, we have to talk about cerebral perfusion pressure as it is important. You can press a pause and read this slide, but the main reason is to know because during the procedure we have to cross clamp the carotid artery during the inflation of the balloon, and of course the flux and flow of the blood to the brain will be decreased and even to the zero. For this reason we have to know what is this cerebral perfusion pressure and components, what compounds this pressure. Methods for assessing cerebral perfusion, it's by measuring mean arterial blood pressure and insertion of an interventricular catheter. It is not done usually, as you will not insert for every patient intraventricular catheter to measure perfusion pressure, only for stent installation. Pre-anesthetic preparation of the patient will be in the following way, like administering clopidogrel 75 mg 4 to 5 days before surgery, as well as acetyl salicylic acid 75 mg for 4 to 5 days before surgery, or it is called also dual platelet anticoagulation therapy. Stopping warfarin 5 days before surgery, and performing repeated INR and prothrombin time test 24 hours before surgery. If they have not been administered these drugs, clopidogrel and acetyl salicylic acid, the method of administration shall be used like clopidogrel 300 mg 4 to 5 hours before surgery, but in most cases we do so to apply 5 days before surgery, a dual antiplatelet anticoagulation therapy, because it is most safety. So patient safety is first. Apply elastic bandages immediately before surgery to patients with vein pathologies like varicose veins of the lower limbs, and infusion of solutions, any crystalline solutions like 500 milliliters 1 hour before surgery to hydrate patient and fulfill the vessel bed. What types of anesthesia are applied to the carotid artery stenting? We have sedation, continuous anesthetic monitoring, and general anesthesia. So I'll start with continuous anesthetic monitoring and what it does mean. You can make a premedication or even do not administer anything to the patient, only infusion, and monitor patient during all the stages or all the periods of the operation, like during balloon inflation or stent placing or anything like that, or decreasing blood pressure to accommodate and to normalize the vital signs. Also, you can apply mild to moderate sedation to the patient as it feels more comfortable and motionless, and even a surgeon can operate or neurologist, that is neurointerventionist, can work well as patient is not agitated or motion. And general anesthesia is applied rarely because it is not necessary and only for patients who do not cooperate well with a surgeon. So once again, heparin is administered at a dose of 70 to 100 units, international units per kilogram to reach ACT values 200 to 250 seconds. ACT is activated clotting time and is measured 2 minutes immediately after administration of heparin. Bivalirudin is another drug that is direct thrombin inhibitor, which is an effective alternative to heparin due to its short half-life of 25 minutes instead of heparin, which have 1 hour, and at a dose of 1 milligram per kilogram bolus, followed by infusion of 0.2 milligram per kilogram. And subsequently, heparin is administered repeatedly under the control of ACT. If you administer it right now, heparin dose like 5,000 units after 1 hour, as half time is 1 hour, you have to check once again ACT or administer additional dose. During balloon inflation, the risk of ischemia may be reduced by maintaining normal or high infusion pressure. So infusion of patient with normal saline solutions is adequate for maintaining this volemia and maintaining optimal blood flow that result in rapid recovery of the patient. Hemodynamics during manipulations of the sinus caroticus with excitation of the nerve herring, which is a small branch of the glossopharyngeal nerve, is perceived as an increased blood pressure and reflectorily tends to bradycardia and hypotension. And in severe cases, it can lead to cardiac arrest with involvement of vagus nerve. So glossopharyngeal nerve is afferent and vagus nerve is efferent, going to the target organs. And it requires vigilance in preventing bradycardia by atropinization of patient with dosage like 0.3 to 0.5 or 6 milligram, and maintaining adequate intra and pre-anesthetic infusion as well. But if patient responding with bradycardia and hypotension during the balloon inflation, the most possible cause will be, of course, carotid sinus and receptors. So you're doing firstly atropinization of the patient, and at the same time you are giving high flow infusion of solutions. Some complications can occur during the procedure and after the procedure, like brain stroke, intracranial hemorrhage, carotid perforation, acute flow diverter thrombosis at the level of vascular access. So all of them are major complications. Some of them are rare, as you see in this one, acute flow diverter thrombosis, because flow diverter thrombosis is installed rarely and mostly for any aneurysm at this level. Minor complications like carotid artery spasm, bradycardia, hypotension, cardiac arrest, a carotid artery dissection, post-contrast encephalopathy, and transient ischemic attack. Most of them can be prevented by some mechanical or physical appliances. Distal embolizations that is caused by the release into the bloodstream of thrombotic, necrotic, or atherosclerotic material or of any type, and can produce acute transiemic attack or stroke, and preventing this by administration of dual anticoagulant therapy with clopidogrel and aspirin, or and effective heparinization during the procedure with ACT verification. Minimizing, of course, aggressive manipulations with a catheter, both with the moment of dilation and with balloon. Installing of the catheter and balloon dilation. Intracranial hemorrhage, once suspected, the procedure is terminated immediately and the anticoagulation is reversed. And it is performed with protamine sulfate that is antagonist to heparin. And you see the report like a ratio like 1 milligram of protamine to 100 units of heparin. In carotid artery spasm, it resolves spontaneously when the catheter is removed from that portion, or intracranial intraarterial administration of any of the drugs like nitroglycerin, papaverine, verapamil, and nematob. Most of them are effective and used still by surgeons. Correction of causes of hypotension like volume depletion, solution infusion like crystalline, any of them, and vascular excess hemorrhage. So in any hemorrhage, you have to give patient replenishment with volume and administer concentration of erythrocyte according to the general blood test, as you are not transfusing to any patient blood prior to see the level of hemoglobin and erythrocytes and hematocrit. Carotid artery spasm, we talked previously. Bradycardia and hypotension. This is a transient phenomena commonly encountered in response to balloon dilation and even to the catheter insertion at the carotid bifurcation level, and are effectively avoided by premedication with atropine like 0.5 to 1 milligram by one dosage. High doses of atropine should be avoided in elderly patients having a confusing effect and for subsequent radiological examination to be informative. Also want to mention that administration of light sedation or mild to moderate is okay, but when you do a deep sedation, patient have the risk to become less responsive to atropine therapy and more responsive to bradycardia and hypotension that is provoked by balloon dilation. Correction of causes of hypotension. So post-anesthetic period, we are giving oxygen to the patient like 3 liters per minute with a nasal cannula or face mask, and prophylaxis of the gastric ulcers like H2 blockers or proton pump inhibitors. Also solution infusion like 1,500 or 2,000 for 24 hours. The question is, should we administer intravenously these solutions or give patient per oral administration of liquids? Of course, IV administration is certainly into the vessel and fulfill vessel, independently of what the patient state like absorption or anything like that. Antibiotic prophylaxis, 1 dose or no dose, and maintaining blood pressure less than 130 per 80 millimeters of mercury, or normal blood pressure with different drugs like tachybane, Isocat, or anything else that can help. Or if patient is on any long period administration of tableted therapy, he can follow this therapy. Cerebral hyperperfusion syndrome can appear and we are doing the stabilization of the blood pressure to normal range to prevent this hyperperfusion syndrome. After restoration of full consciousness and the presence of peristalsis, a patient can start feeding and drink liquids. Thank you very much for your attention. Hope this video is interesting for you, especially if you are working as anesthesiologist in neuro-interventional radiology. Have a great time.